All right, good evening to everyone. We have about 30 seconds before our official start time. So just make sure that your name and your campus is in the chat. Just as a reminder, these sessions are recorded and they are viewed by the attendance administrators. Ensure that you're on camera, that you're in that professional setting, at all times throughout the class. So just make sure that you are abiding by that professionalism uh, rubric that is out there that we grade you on every week. So just make sure that you're adhering to those things. Anytime that you have to be away from the camera, put a message in the chat to myself. Don't send it out to everyone. Just make sure you put a message in the chat, whatever it is that you have going on, restroom or whatever it is. So welcome to week 4. Again, make sure, I didn't say this, but make sure your name, first and your last name appears on the screen as it does also on the roster. Sometimes, these computers or devices, it changes what your name is. Sometimes I'm not sure what the algorithm is for that, but just make sure that it matches. So when the attendance administrators say, hey, this person was not in class, we can in fact say for sure they was not in class or they were in class because it matched what the roster said. So if you're undergoing a name change and it hasn't occurred yet on the roster, just put however it listed on the roster. Just list your name. All right, so welcome to week 4. Congratulations to you all. You all rocked last week on unit exam 1. So think about those things that you did. You reviewed your classroom recordings, you looked at your PowerPoints, your required readings, you thought back on your prior knowledge because you're bringing all of those tools that you already have in your toolkit from OB, med surgeon, all those different places, those clinicals, other classrooms, you're bringing it on to leadership. So just think about those things that you might need to do a little bit different so you can improve on that score. If you need to create flashcards, if you need a study partner, if you need that one-on-one, just think about those small changes that will be really, really huge that can be really positively impactful on your score. And also remember, you will have an NCLEX, you will have HESI. So, we're just trying to get from week to week, but consider the bigger picture as well. So kudos to you all. So again, make sure you put your name and your campus in the chat. We will do that Jeopardy. We provided a Jeopardy for you all in the announcement section. We'll kind of do that and see how we are to see where we are at with our prior knowledge. And then we'll look at our PowerPoints and then we have a case study in the end. And then at the very end, we'll let you all meet again briefly in your groups. So let me get that Jeopardy pulled up. Let's see here. Let's see if I can we're in week 4, you all. So we meet this week and next week for content. And then your next exam is week 6. Week 6, it comes by pretty quickly. So just keep that in mind as well. Time just moves really fast, especially after that first exam. So for those of you that are taking more than one class, go back and be checking your schedules, looking at those dates when those exams are, so that you can be rearranging, deleting, or putting things on pause so that you can, fulfill all of those requirements here. Let's see. Pull up this Jeopardy that we put in for you. I can get it pulled up here. I'll share my screen here in just a few. And you all tell me what to select. I say Jeopardy, but I think it's actually the Millionaire Game platform that we utilizing here. Okay. All right. So feel free to come off mute and read through, because remember those test taking tips. You want to read through, make sure you understand what the concept is that the question is about, and then answer what the question is really asking you about that concept. Okay. So
Hi, Professor. Can I ask a question? I was waiting for 5 or 6 minutes. What am I going to be considered late?
5 or 6 minutes to get in class.
Yes, I've been waiting since before 5:30.
Oh, I'm not. Well, no. If you're in fact logged into the waiting area, everything is timestamped. No.
Okay, thank you.
Mm-hmm. But as you all name appears on the screen, we click you in. But nevertheless, the waiting room is timestamped, and that's considered being in. So again, we have this millionaire game here, and identify what the concept is, and then see what it's asking you about the concept as you read through. So wait before you start reading, because I want to be quiet so you can have, you can concentrate. So as you read through the answer choices, remember the entire answer choice has to be correct in order for you to select that. So be careful when the answer choice is partially correct. Okay. All right. So I'll be quiet. So in the chat, just put 1, 2, 3, or 4. And then as we move on, we'll let you come off mute and respond. Okay, I'm going to look over here in the chat and see what we're getting. Let's see, 1, 2, 3, or 4 here. Got 1 and we have 4, mostly 1s look like. We have 2 4s. Okay, let's look at 1 and 4. So we've narrowed down to 1 and 4. So 1 says assertive, so let's read this statement. Which statement best describes the impact of assertive communication in nursing practice? So someone come off mute and tell me, what is this question? What is the concept? And what is this question asking you to answer about the concept? So the question is, the concept is, go ahead. Go ahead.
I was just going to say, basically, it's just what's most effective out of using assertive communication.
So the concept is assertive communication. Then it's asking you a positive impact. What is correct about? Rochelle, say it again. How did you word it? What's correct about assertive communication? What's a positive impact? And what did you say?
I said, how effective, like the effectiveness of the assertive medication.
The effectiveness
of saying my
it.
name correctly.
Say what now?
So thank you for saying my name correctly.
Oh, just because you said I'll mess it up. So don't, no harm intended if I mess it up. So she said effective versus ineffective. I said positive versus negative. What was the other thing I said? Which best matches. So when you're reading through, once you identify what the concept is, what is this question asking you about the concept? And then you read through and see which one best matches that. Okay, so we got one says assertive communication promotes positive relationships and establishes trust. 4 says assertive communication is primarily used to avoid conflict. Okay, so we narrow down to 1 and 4. So let's see. Let me go back to my chat to see where we're at now. How many more 1s do we have, or 4s? So for the ones that selected 4 and 1, tell me, why did you select 1 or 4? And if you select 4 and you change your mind, tell us why you changed your mind.
I selected 4 because assertive communication is usually very direct.
Okay, it is direct, and it is it is honest. It is not that you're breaking rules. Is it aggressive? Is assertive communication aggressive?
It depends on the delivery.
So assertive is not aggressive. If the delivery is aggressive, then it's aggressive communication. Assertive, sometimes people think because you're telling the truth, you telling them what the rules are, what's the next steps, what the doctor has ordered. They may want you to provide some information to them, but if you let them know, being honest and say, hey, I can't provide you that information, but I can get you someone that can. The tone, long as your tone is okay, that is assertive. Being honest with that person, letting them know. And if a person's being nasty, being belittling, threatening, that's not assertive. That's aggressive communication. Okay. Someone else, tell me why you selected number 1.
I selected number one because when you use assertive communication, you are building trust with that person because you're being direct and there's no wiggle room in what you're saying and you're giving them the right and honest answer. Whether they like it or not, that's a different story, but you're building that relationship out of that. And then it creates a positive experience for everybody involved.
Okay. With hearing our discussion from the three of us, again, respond in the chat, 1 of 4. And I'm going to go to the chat, 1 of 4. Hearing a discussion about assertive communication, aggressive. What are you saying now? Just drop 1 of 4 in the chat. Okay. All right, let's select number 1 and see what it tells us. Okay, so that is correct. So again, if the communication is threatening, if it's negative, if the person is being dishonest, if the tone is all wrong, then that's being aggressive. Okay. All right. So let's look at this one, and I'll be quiet and let you read through. Remember the test taking tips. Remember what we said about what assertive was. Identify the concept. I will give you a hint. Identify the concept. Answer what it is asking you to about the concept. Look for keywords. You know, we say tomato, tomato, but they mean the same thing. So, what is the concept in this? What's the concept? Someone come off mute and tell me.
Passive behavior.
So non-assertive behavior, but the context clue is passive. So tomato, tomato, if you're saying non-assertive or if you're saying passive, they mean the same thing. So knowing that, and it's asking you which characteristic is most commonly associated. So which statement matches being passive / non-assertive? We just said what assertive was. And we talked about what aggressive was. Okay, now drop it in the chat. 1, 2, 3, or 4. Scroll down here. Let me slide us over here. Okay, keep dropping. Looks like we have 2. Let me see. Is that our final answer? Is that our final answer? I see heads going up and down, which I think they're saying yes. Okay, let's see. Let's see. How do we do? Okay, yes, non-assertive is passive. They're avoiding conflict, so they're not being honest. If the patient has questions, even if they want a right now answer, sometimes you might not have that answer, and it's okay to say, hey, I don't have the answer, let me reach out, rather than trying to give them an answer or being rushed because the patient is actually being rushed. So, or not answering that question. Oh, they'll answer that for you when the next person comes in. Okay. All right, so here we go. A client asks a nurse for information about their illness. That nurse does not know. Which response demonstrates assertive communication? I'll give you a minute to read through the answer choices. Let me find my little timer here. Because I think I've been giving y'all a minute and I really don't. So let me go to my timer. Let's see. Think about a test taking tips. What is the main concept? What are they asking you about the concept? Is it a positive or negative about the concept? Answer choice has to be correct entirety, not part of the answer choice. and put your selection in the chat. So far, we have 2 out of 2. Let's see, can we keep it going? So our main concept here is assertive communication. And so look for those words. Well, what is it that they want us to answer about assertive communication? The words demonstrates means that for this, they want you to select a statement that matches or is positive or indicates that the communication is assertive. Okay. All right. So our minute is up. All right. Let's see what we put in the chat. 1, 2, 3, or 4. Okay. So we have 2s and O's. Oh, you meant to put 1. Okay. You meant to put 2. Okay. Okay. I see. Okay. So it looks like we have 2. Okay. Let's see you all. Let's see. Let's see what it's going to tell us. Okay. So demonstrates. So it wants you to pick something that matches or is. So that's another example. That scenario was an example of knowing the concept and then applying what you know. So it wasn't like a definition. Well, the question was not a definition. Well, what is define assertiveness? You had to know what that was in order to pick out a statement. Okay, so you got to know the concepts. Here we go again. Which of the following is an example of assertive body language? So, we speak in nonverbal and verbal cues. So this is talking about nonverbal. So which body language? We just said aggressive was a threatening manner. We said being dishonest, not telling the truth. Non-assertive was passing the buck, being passive, not really answering questions. So define what assertive is in your mind, and then pick out which body language, which nonverbal cue indicates assertive. Okay, 1, 2, 3, or 4. Drop it in the chat. Avoiding eye contact and speaking hesitantly. Crossing the arms and speaking in a low tone. Looking away and swaying from foot to foot. Standing straight, maintaining eye contact, and speaking with ease. Okay, let's see what we got. Okay, looks like the 4s have it. Let's see what we got. So it is a thing of sustained eye contact. That's kind of offensive, but just maintaining eye contact here means, look at the person, make eye contact, maybe look away, and your voice is not so loud, your voice is not so low that they can't hear you. Okay, did pretty good. Remember, crossing arms, that's kind of like you're on the offensive. So usually your hands are down by your side. Okay. What are the 3 rules for assertiveness described in the text? Okay, I'll give you 1 minute, 30 seconds to read through. Let's see here. Okay. Okay, drop it in the chat. 1, 2, 3, 4. Remember our test taking tips. Identify the concept, assertiveness. Then it says, what are 3 rules? So we're looking for something that's positive, that matches, that indicates assertiveness. Not non-assertive, not aggressive. And then sometimes you'll have to think about other terms to kind of refocus you so that you can, refocus and understand, bring to your remembrance of what that term is. That's why I mentioned it's not aggressive, it's not non-assertive or passive. Okay. And then if you don't quite understand what the question is saying, take the time to reread it, because remember, you do have those exams, you do have that amount of time. You have the time to take it. So let's see. We're saying fours again. Okay, our time is up. Let's see. What are the 3 rules for assertiveness described in the text? Own your feelings, make them known directly, and ensure nonverbal communication matches your verbal message. Let's see. All right, we're doing good so far. All right, let's see. What is the potential consequence of aggressive behavior? Aggressive, assertiveness, non-assertive / passive. So here it is, aggressive. So it's asking you a consequence. Okay, and let me start my timer. You can do process of elimination. Well, what are some things that you know that are outright not, that does not match or line up or indicates aggressive behavior? You know, what are some things that do, however you want to look at it, test taking tips and strategies. Go back to those strategies that you use. Okay, put it in the chat, 1, 2, 3, or 4. Okay, let's see what we got here in the chat. Okay, looks like the ones have it. Let's see. A consequence of aggressive behavior. Okay, all right. So aggressive is the opposite of assertive. Assertive is open and honest, considering others. Aggressive is threatening, it's difficult. That person is more likely to be difficult to work with. Okay, so we have another one. How do assertive nurses typically respond? We start our timer here. How do assertive nurses typically respond to criticism of their work? Okay, we know what assertive is now. So how would a person how would they respond if they're usually assertive versus aggressive? Which would these responses match a person that's been assertive? Okay, in the chat, 1, 2, 3, or 4. Are we going to, will an assertive nurse avoid criticism? Would that nurse blame others if they're assertive? Would that nurse separate the criticism of their performance from criticisms of themselves? Or would that nurse just internalize and think about it, that criticism, and just feel devastated? And as I just did, what I just did, as you read through your answer choices, you don't change what the answer choices are saying, but you may want to paraphrase them and say them to yourselves. That's a test taking tip 2. Okay, let me go to the chat. Let's see what you put in, what we're going to select. Let's see. We have 2s, I think, for this one. Okay. So assertive nurses, they typically respond, they separate the criticism of their performance from criticism of themselves. Okay. Okay. And I guess that word criticism, it kind of can throw you off, but it constructive criticism, because we all have strengths and weaknesses. So if there are identifying criticisms, it's things that can help us to be safer, better nurses, can help us manage our time better, and things like that. So that criticism is not anything to hurt you. hurt your feelings or anything, but it's so that we can all grow and do better. And that's all of us. All right. Which statement best defines assertiveness in the context of nursing? All right, and start my timer. So identify the concept. Looks like it's still assertiveness. And it's asking you which one best defines or matches, or is correct, or is positive, or indicates assertive. Okay. 1, 2, 3, or 4. We're almost there. We're gonna get all our points. Looks like it so far. Okay. A few more seconds. All right, let me go to the chat, see what we got. Looks like we have the 3s. Okay, assertiveness involves expressing oneself honestly while respecting the rights of others, because we just said assertiveness was being honest. So we just said aggressive communication was dishonest, belittling, in a threatening manner. So assertiveness is not that. So automatically there are some answer choices you can outright say no, that this is not it. And you can go through and eliminate those once you've identified the concept and what the question is asking you. Those are just placeholders. Okay. So you all said number 3. Let me go back to my chat. Make sure I don't select the wrong one. You all said number 3. Okay. Right. As I forget which one of you are, but you said that it just depends on, the person or the situation. But as long as you're being honest, sometimes it may, that other person that's receiving information, they may become aggressive because what they're hearing might not be necessarily what they want. But it's still, we want to still be assertive and tell the truth. And those things that we don't have an answer to, we'll seek out a solution for. So we still want to be assertive. Okay. All right. Let's see where we're at. We're almost there, you are. Okay. What is one benefit of assertiveness for nurses? So what is something that's good? What is something that's positive? A good effect, positive outcome? Got a timer on. Okay. Let's look in the chat and see what we got. Okay. We're mostly saying 1. Okay. So assertiveness, right? We're being honest. We're telling them the truth. We're giving them all the information. It does not mean it's gonna, be conflict free, because if what you're saying sometimes is not what the person is thinking that they should be receiving or the answer that they want. Sometimes conflict will come with that. So it does not mean that it's going to prevent all. And so look for those little words. They're small words, but they change the whole definition. And so look for those. I forget what you call them. They're little, I don't want to say they're fillers. They're not fillers, but just watch those words. All, but, and, every, for, and just be careful with picking those answer choices. Let me go back again and see what we said, just to make sure. Uh-oh. Okay, you all said number 1 allows nurses to experience a sense of control over their emotions and responses. Because you're just keeping to what the policy and procedure says, which comes directly from your Nurse Practice Act. So you're practicing within your scope of practice. You're practicing and you're giving them information based on, your information, your foundation, what you know is correct. Even if it means, hey, I don't have the answer, let me reach out and find someone else that does have the answer. You're being honest with them. Okay, we did pretty good on that. All right, so what we're going to do is look through our PowerPoints, and then we have a case study that we're going to look at too as well, and then we'll get in our group. So that's where we're kind of at in our pathway here. Make sure you put your name and campus in the chat, you all, if you haven't done so. Let me pull up our PowerPoints here. Okay, just waiting on them to open it. Okay, and slideshow from the current slide. So you all make sure that you're in the appropriate setting. If you have to walk away from the camera, make sure you put a message in the chat to me stating what's going on. All right, so communication. We kind of started talking about it, but this is more specific. We have a person that's a sender and a receiver. How are we communicating? Is it verbal? Is it written? Is it through pictures? So what did I think of an example of pictures? A lot of times we do the glucometers now. Most of them turn on when you place the little slip inside, the little not the lancet, the test strip. Most of them turn on. Rarely do you have to hit the on button unless you're trying to recall and look and see what a previous number is. Then there's some that you still have to turn it on. But if you place that drop of blood on there before that screen indicates drop blood on there, then it is not going to read correctly. So there are different sources of communication, verbal, and there's nonverbal. You have pictures sometimes with discharge instructions. The person will get the packet in writing. Person will come in and talk, and then of course, we as LPNs will come back in and we'll reinforce that information, have another conversation with the patient. But they have those videos for them. They have pictures and all different types of things. But we want to make sure that the person that's receiving the information is actually receiving what is being sent, because sometimes there's miscommunication. So there's a sender and a receiver. And so we want to consider different things when we're actually communicating with people. So situational, is it cold? Like we go in and do that head to toe assessment for a patient, or we're just going in to check on them and it's cold in the room. We're asking them questions and they're not responding to us because they're shivering, or it's the opposite, is too hot, or they could be in pain. So they can't concentrate on the information that we're trying to send to them. They're not going to receive it because the situation impedes or stops or hinders what we're trying to communicate. A lot of times, if we know that we have a patient that has a dressing change, and we know that that wound has an odor, we'll go in. First of all, if they've been complaining of pain, we'll ask them, do they want that pain medication prior to? But then a lot of places, they don't have like air fresheners per se, but they may open the window, or they may have like, I think peppermint drops or something that you can put in just to help with the situation. All buzzers and alarms, we need to answer those things quickly and resolve them, because otherwise it will affect the information that we're trying to either receive or send to our patients. We do want to consider personal space, and also that eye contact. Maintaining eye contact is different from just sustained eye contact, like with glaring eyes. That's considered offensive. Some touch, on the shoulder is fine. In some cultures, it is not okay. But that's where you gather that information, where you talk to your patient and you identify things that are important to them. So moving forward, we can incorporate that information in their plan of care. We'll be reminded of that. Talked about that nonverbal I think in the scenario was the arms were folded. We don't want glaring eyes, but we do want to make eye contact. We do want to speak in a tone so that person can actually hear us. And we do want to put information in that person's first language, whatever that is. If that person's first language is German, we want to make sure that all those things that we're giving, if it's handouts, if it's a video, or if we're talking, we may have to bring in a translator that is in their first language, whatever their first language is. Because otherwise, what we're communicating, it's not communicated because we don't understand what the person is telling us. So nonverbal, verbal, and effective communication. Spoken word is powerful. Nonverbal communication is powerful and can both support or counsel the meaning of verbal communication. So you want to make sure that what you're saying also lines up with your nonverbal, those body language, those body cues that we're doing. Like we are saying, yes, it's okay, but then we're pulling away or we're, cringing. A lot of times we'll see that our patients may say, oh, I'm not in any pain, but we'll see them. Their facial grimacing, they may be moaning, they may be guarding. And then we will go back and, ask again, and we'll make sure that they understand what we're asking them is about the pain. Are you in any discomfort or pain right now? So we want to be sure to implement all strategies to ensure a minimum impact to nonverbal behavior. We want to make sure those things actually line up. So some other nonverbal behaviors, yawning, the person's talking to us and, we're supposed to be interested in what they're saying, and we're yawning and looking away and talking while others, while we're actually supposed to be talking to our patients, not making eye contact at all, looking bored or distracted, facial grimacing, we're glaring eyes, we're frown. And then the volume of our voice, if it's too loud or if it's too low, the person can't understand you. So we want to make sure that it is at appropriate tone. If a person has a problem with hearing, we don't want to talk in the ear that they have a problem with hearing, that they're hearing impaired. A lot of times they read your lips, so we want to make sure that we're standing in front of them and then speaking at that tone. Speaking louder actually distorts what you're saying, so that does not help a person that's hearing impaired. So active listening behaviors. So these are some strategies that we can use to ensure that the information that we have received is actually correct. We can restate. So we are repeating what the patient said in a slightly different way. Clarifying, we ask questions in response to what the client has told us. Okay, just to make sure. Let me ask you this question. I heard you say, does it mean, so that's how that little conversation might go. So reflecting, putting into words the information you receive from the client at an effective communication level. Just making sure the words that we're using, the words that they use, and make sure we really understood what they said, because they may use a word that we don't know the meaning to, and we for sure want to ask if they really understand what we're talking about. So we do want to talk in layman's terms. Just make it as plain as possible. We don't want to change the definition of what we're trying to convey to our patient. So paraphrasing, we're going to talk back to our patient, speak back, repeat back what they said, but we're going to put it into our own words. We're not changing what they're saying. And all of these things are done just to ensure what has been sent, the message that was communicated, is really, in fact, what was communicated, because there is a such thing as miscommunication. So minimum encouraging. So that's what we use, the sounds of words that encourages that person to continue to talk. We may motion our head. We may do a hand motion. We may say, okay, continue. Things like that. And believe it or not, you all, remaining silent while someone's speaking and just getting it all out, it's therapeutic. Without interruptions. We want to remain silent, just let them get it all out, ask questions. Sometimes they may even have to write down some things to get their thoughts together. And that's okay. We want to allow them time to do that. Okay, summarizing, you want to state the main idea. Patient, sometimes Even we'll just go on and on about things. But then there's this main idea or 2 or 3 points. So then we come back and say, okay, I just want to go back over what you said. Now, these are the 3 points or the 4 things that I've heard you say. Let me know if this is correct or not. And then validating allows the client to correct the information when summarized. Once we get it back to them, we talk, we convey to them what we thought we heard and understood. But then the patient will say, well, okay, yes, that's what I mean. Or no, you got that wrong. Okay. Open-ended versus closed-ended questions. One of them pretty much gives you a yes or no answer. And the other one, you gather more information. Which one is pretty much yes or no? Or a specific answer? Is it closed or open?
Closed-ended.
Okay, closed-ended. Okay, now open is just, sometimes you may have to, refocus them. Because sometimes you know how we get to talking and talking. And then, sometimes one thought leads to another thought. But nevertheless, open, you'll get more information. Okay. And then once you get that information, we have to go in and ask this focus question, which we're focused on those 3 main points that they said. So we go back and ask more information or questions about those 3 main points rather than all those other things that they talked about. Okay. So positive communication behaviors. I am encouraging positive communication using I messages, establishing that eye contact, expressing empathy. We might not know exactly what the patient is experiencing or the person is experiencing, but because we know they're human, we're human, we express that empathy, that care and concern for them. Using open communications, we want to be aware of our body language. We talked about that posture, the slump, if we're looking away or, we're slouched down or something like that, we want to make sure that our posture in our body language, our frowning, you're changing that doing that dressing change, and you're all frowned up. I mean, that person's hurting. They, don't want that wound either. So don't make the patient feel worse by frowning and making sounds and remarks regarding what the dressing, the wound actually looks like. So just be careful with that. Okay, so let's look at negative communication. Let me go back to the positive communication, that remaining silent. For the most part, sometimes people think it's negative, but it's okay to be silent. Negative communication, this one right here is what we have. They're so quick that the patient said, nurse, nurse Rashid, nurse Lisa, what would you do? We don't want to give them advice. That's negative. But we do want to make sure our patients, our residents, whatever setting you're in, that they have enough information so that they make an informed decision. But giving advice is actually negative. Okay. We don't want to give false reassurance. Oh, everything is going to be okay. And we're definitely not asking about patients' information that has nothing to do with their care. You have a patient in and their family member on their mom's side or something like that. And the questions we're asking them has nothing to do with the care that we're going to provide. So that is considered negative. And when you don't know that, you must be, the reason you're having this procedure done just because, I don't know, you eat a lot of M&Ms or you only eat apples. We don't want to make statements like that. That is considered negative. Role changes for the client. Of course, introduce yourself, nursing jargon. We want to use layman's terms. And of course, this patient is there. They are afraid. They may not verbally voice it, but their life, their body systems are not functioning properly. They're in pain. They don't understand what's happening to them. They hear people calling out lab values and all of this stuff. Where this is this and this and that. We need to put you on this. We need to start an IV. We need to do this procedure. They are afraid. And that's a normal human response. So we do want to be assertive, be honest, and we do want to make sure they have enough information so that they can make informed decisions. So communicating with instructors, and staff, everybody on the healthcare team. We have physical therapists, respiratory, healthcare providers. We have social services. We have patients. Sometimes they will have that proxy, which is someone that makes decisions for them. It might not necessarily be that family member that you've been seeing at that bedside all along. But nevertheless, we do want to be respectful. We want to be honest with those persons. There might, even if there's something going wrong, there's conflict. We still just want to be respectful. We want to be honest, follow what those policies and procedures say, which should match what our nurses state practice act says. Okay. So SBAR, someone come off mute and tell us what we use SBAR for. What does this help us do?
It's assessing the patient. You start with while they're there, you get their background history, you do your assessment, and you give your recommendation.
Okay. So it helps us to communicate in that structured way. So we pretty much won't forget anything. So I'm sure by now you all have done the handoff reports. You use SBAR you're going home and you give report to the nurse that you're leaving the care for your client. We can also use SBAR when we're communicating with the healthcare providers to let them know about a change or something that's going on with our client. But this SBAR, it helps us to communicate in a structured way so that we pretty much don't leave out anything. Okay. And so we do want to make sure we do know what falls under each one of these parts. So I'll make sure we'll read through this slide here. Okay. How to use this we're making a call to the healthcare provider, that physician. Remember, the physicians want information that's brief and to the point. They want to know who you are, who we're talking about, where is this client located at, situation. What is the reason? Why are we calling? Change in a client's level of consciousness, pain medications not working. We have a critical lab value. The client they took Tylenol and they're itching. They're having some type of allergic reaction. Why are we calling? What is the reason for that call? Of course, we tell them who we are, identify the client, and what's going on. Background. So they need to know a little bit about that person. Like, what's their past medical history? When did they come in? What did they come in for? Are they a DNR or full code? Because if we're calling them because there's been a change of level of consciousness, blood pressure is dropping, or there's no blood pressure, no pulse. They need to know whether or not this person is a full code or did not resuscitate. So again, with that background, we give what medications they're on. We're calling because we administer pain medication or antihypertensive. We go in to do our routine vital signs. That blood pressure is still up. We go in to reassess our client. That client is crying, their facial grimacing, that pain medication hadn't touched them. So the healthcare provider needs to know what medications have they already taken? When was it? What was the dose? So for assessment, what you think is going on based on the data findings. And of course, we're going to collaborate with that RN as needed. For example, is this problem life-threatening? Is this a huge change in this client status? Or, do we need to change the setting? And the setting could be from med-surg. This person may need to be transferred to another facility, might need to be transferred to ICU. What is it? And then recommendations. What are those goals of care? What needs to be done, including consults? Should there be a transfer or a medication order for this? Do we need to recheck the blood pressure? Do we need to go ahead and administer the medication at whatever that next scheduled time is? And then we have this slide speaks to when we're just handing off report to the other nurse that's coming on that's going to take care of this client. Now, we've seen these handoff reports done on using a cardiac. Sometimes, I'm sure you all have seen those in the hospital. Sometimes you'll see where the nurses actually record so they can go back and replay. They have like these recorders. Sometimes it's bedside. They walk around and give this report at the client's bedside. And you'll see it done differently. But nevertheless, we're communicating to the next person or the person that's in charge of that client's care, the healthcare provider or the next nurse that's going to take charge while you're leaving. So again, what is the situation? When did they come in? What did they come in? What was the reason? Why are they there? Background, because rarely there's a person there with one thing. Well, this person came in because their glucoses were low. But this person also may have hypertension. This person also may have just gotten the hip replaced. So what else is it? We need to know that background. Of course, code status, pain management strategies. Have we received any lab results? Are there any lab results that we should be expecting? Because most of the times when labs are drawn and like chest x-rays, different procedures are done, sometimes if it's not order stat, we don't get those results back pretty quickly. But you want to let that next nurse know, hey, be looking out for this, because we got a chest x-ray done this morning. Those results should be coming in pretty quickly. And sometimes they will call on the phone, and they will send a fax or some other type of communication to that floor or that unit where that patient is actually residing. So assessment, we're going to let them know what those vital signs were, what the pain assessment findings were, any medications prescribed, anything that we had to administer during that shift. And then the recommendation, what are those goals of care? What needs to be done for the next shift? Are there any procedures there, any carryover that needs to be done? So when we're responding to our clients, we do want to consider, well, what is the age of the client? Because if our patients are infants, then we're going to be talking to the parent or guardian. So, but then if we're on peds, we're going to talk to the parent or guardian and also the actual patient, the toddler. So we want to make sure that we are using, terms that both can understand. But nevertheless, if they're under the legal age, then we're going to also talk to that parent or guardian as well. And then for adolescents, it can be either the easiest or the most difficult to communicate with, because you just never know. They're growing, they're trying to be independent, faced with so many challenges. And, on the opposite, they're growing and may think they have all the answers. And then we're communicating something to them that they might not be aware of, so that may be a little bit uneasy to them. But nevertheless, we still want to be assertive, respectful, and provide that honest communication, not aggressive, even if the conversation leads to being aggressive. We want to stay on the side of being honest and respectful. So email etiquette, I'm sure you all know about this right here. We don't use the all caps. We do want to, spell out things. We want to skip a line when we're talking about different subjects within that same email. We do want to make sure we're sending that message to the correct person, because there's sometimes, people have names that are similar. And so we just want to make sure we don't want to send information to the wrong person. We want to be cautious with humor, even if we're email or we're talking. We want to, because some things can be received as offensive, or someone can, be thinking you're talking about something else when you really are not. So be careful with trying to just be funny and lightening the mood. So just be careful with that, because it can be received negatively or just incorrectly received. Okay. So when charting, whether or not it's electronic, you all, or on paper, here, I haven't heard it here lately where systems were being, what do you call that, held ransom, and people couldn't get into their chart. So they were having to refer back to paper, pen and paper. But nevertheless, you want to always take the time to write down what happened during your shift, because they have to refer back a year from now or 2 years from now. Yes, they may get your verbal testimony, but they're going to go back and look and see what you actually charted, whether or not it was written, pen and paper, or if you actually documented electronically. So make sure that your times and dates are there. Make sure what you're saying is clear and brief to the point. You want to avoid using those terms that people can misunderstand, like the blood pressure was normal. Well, just write what that person's blood pressure was. Blood pressure was 120/80 in left arm, sitting. Be as specific as you can. O2 saturation was 98% on room air, or O2 was 98% on oxygen per nasal cannula. Be as specific and to the point as you can. I think it's about time to take our first break, you all. And we got a few more minutes. So other types of communication. A lot of facilities, you all may have seen this in the skilled nursing facilities and the hospitals. They have all these other types of ways of communicating. They may have pagers. What's the other thing? They have names for them, but it's like a cell phone and a pager mix. I can't think of the name right now, but there are different ways of communication. But just make sure that we're communicating things that should be communicated. Always remember HIPAA. If you're communicating patient information, make sure that you're not using your own personal phone and you don't have these group text messages going around. Just be careful with that, because if you're violating HIPAA, we know violations of HIPAA can lead to, some things that are not so good. So just be careful. Make sure we're using appropriate systems, because for the most part, everyone has these electronic systems now. Make sure we're communicating within those systems, because they have the firewalls, they have those, I don't know what you call them, but for example, if you're taking care of the patient in the emergency room and the patient has been sent to med-surg, you can't log in to that med-surg portal and see that patient's information. So they have all these safety parameters off inside of these systems. So, but that's there to protect you and that patient, because if you start talking about something on your own personal phone and HIPAA is violated, that can be fines, that can be, jail time. So just make sure that we're communicating with the appropriate information on the appropriate sources. Social media, a lot of times facilities will have their, what do they call them, public relations people. They may call it something else. So you can ask, as a matter of fact, that will be an additional task that you'll have as working at that facility. Like they have a health fair, if they have a back to school bash in that community, you may be the one, or the nursing school just graduated. You might be the one that go out and be the face of that organization. So just make sure the things that we're posting and that we have people's permission, whatever that rule is, sometimes is in writing permission or it is, a verbal, but just make sure we're being careful what we're posting and what we're sharing also. Because if we're sharing something that's inappropriate and we shared it, it's just like we put it out there. So be careful with that libel, slander, things like that. So conflict resolution. Accept conflict as a natural part of life. It helps us to work through things. It helps us to think through, could we have done this differently? Is there a different solution? Temper your attitude, your own attitude and behaviors. Be aware of your initial reaction. Just take a deep breath, and be a little patient. Take time to critically think before reacting. We want to treat conflict as an opportunity to voice our own opinion and listen to the other side of the story. Even if sometimes people are creating conflict unnecessarily, we still want to think before reacting, and we want to, make sure that we're responding appropriately. We want to be respectful of each other. See if there's a common ground, to create the highest common denominator, and seek out a solution if so. Okay. All right. So this will take us to the top of our first hour. We will pause and take our 5-minute break. See you in 5. All right. Let me just ask you something. So if a person is standing erect, their posture, their shoulders are back, they're standing straight, arms are not folded, is that assertive or aggressive type behavior?
Assertive.
What if the nurse is trying to communicate something to the client and the nurse states they're expressing what they're saying by saying I statements, I feel, but they're communicating clearly and directly, but they're using that I. Is that assertive? Using I statements, is that considered assertive or aggressive?
That's aggressive.
Do we agree or disagree?
Agreed.
So assertive communication often involves using I statements to express, what we think, what we're feeling, and clearly and directly. The approach is allows us to express honestly without blaming or attacking others. So that's why those I statements are not considered aggressive, because it actually promotes that. It actually promotes communication, that therapeutic relationship, because you're saying, this is I, rather than saying you. So I is actually assertive because it, like I said, eliminates putting blame on the patient. Well, I am doing it this way because policy and procedure states this facilities, this is their rule. They want you to sign in, or they want you to clock in and out with your, like sometimes when visitors come, different facilities, they may have a written log, or they may have something the person go and type their initials in or something like that. And so, this is this is my understanding of what should happen when someone comes to visit their loved one here. That's an open, honest statement. And I'm saying this is my understanding. So I statements are uh, are conducive to being assertive, not aggressive. Okay. So assertiveness, so using those I statements again, it allows us to not to make others feel insulted or what's another word I'm trying, you all help me out. Assertive statements, even though we're being direct and we're not saying it in an
Like
aggressive.
offended?
Say that again.
Belittled or offended,
So
or
it
feeling offended.
exactly, it does. Using those I statements help people not to feel belittled or offended. Good, thank you all. Okay, all right, good. Let's see. Conflict resolution. We had a few slides on that, and so like I said, conflict actually gives us that opportunity. If it's handled, positively, it's an opportunity for that organization to grow as well as us. Because sometimes, we think we have it all, but sometimes those policies and things may need to be revised as long as we align into our state Nurse Practice Act. And so we do want to make sure that we're speaking clearly and making sure that what we're sending to the receiver, that information is clearly communicated. And just know that, there are many of us on the team. We're used to working with Nurse Tom, and then, all of a sudden Nurse Tom, he's on vacation. And now we're having to work with Nurse Lisa. It's fine. We're all on the team. We're all there for that one common goal, to take care of those patients and, to do it lawfully, correctly, and to the best of our ability. So we do want to just know that it'll be, roles will change, and that should not lead to conflict. But even though conflict might arise, it still is an opportunity for growth. We still want to be assertive and not aggressive in those instances. Okay. And know that you may be that person that's on that team, that conflict team. They don't call it the conflict team. They call it I think a resolution or different, some types of committees. But essentially on that committee, when conflict arises, that team will, talk to the patients, they'll talk to the nursing staff, or whoever's involved.
Like the patient advocate.
Advocate. Thank you so much. I don't know what my words said today, but yes, that you can actually, that could be Actually, some facilities, they have a nurse specifically that does that. And then some, they have it, it's part of their role, their day-to-day role. So just be thinking about that. Because conflict is real. It's there. Sometimes people cause it, and sometimes it just happens because things were miscommunicated or misunderstood. So great. That patient advocate. Thank you for helping me out. All right. So I think we have communication down pat. Let's move on to our next little set here. So we can make it through our next 2 sets, and we have a case study, and then we will actually let you all get in your groups and finalize or continue to plan and organize that. Let me pull it up here. I kind of briefly mentioned like working on those teams. It's the podiatrist, it's the eye doctor, it's the physician, it's the physical therapist, the physical therapy aide. There's so many pieces, but it's so important that we coordinate, that care for those clients, that care that we're providing. Now, I don't know if you all went back and hopefully you all went back and looked at the recording for last week. That we're organizing that patient care so that that client, gets the care from all of those different parts of the healthcare team. If the patient is wanting their hair done and the cosmetologist, in skilled nursing facilities, the cosmetologist, they usually have that beauty shop on site. And we know that therapy usually comes at whatever time that morning. We want to coordinate that so the client can get both of those things done. The clients at the beauty shop getting their hair done, and they miss so many of those physical therapy appointments and things like that, then depends on what their insurance says, they can get dropped. And therefore, if that service is dropped, they more than likely will probably have to be discharged because that's the skill that they're part of the skill as why they're actually there and that their insurance company is paying for them to be there. So make sure we consider care coordination. It is fundamental in improving that quality of care while eliminating or decreasing gaps or misuse or underuse in patient care. The patient is scheduled when patients have appointments, like they're in these skilled nursing facilities, and they have to go outside of the facility to receive care from a doctor. And then it's time we schedule them to have a chest x-ray or, I don't know, abdominal x-ray. Well, we know usually those radiology places, they call and say, hey, we're on our way or we're en route. We'll be there within, sometimes it's this huge window, but we don't want them to come to do an x-ray or procedure. And that client, again, is not going to be there because they're out, getting their, getting whatever done at the doctor's office. So coordinating that care. The Patient Protection and Affordable Care Act, they identified care coordination is going to be key in, like I say, ensuring that, that patient does not receive any gaps in care. They're not missing appointments. They're not missing their physical therapy. So we just have to consider all of those things when we're coordinating. It is essential for improving the quality of care, you all, while reducing healthcare costs. Because like I said, one, it can lead to a domino effect. If that person missed too many of their physical therapy appointments, then that person is discharged. Then that person ends back in the hospital, re-hospitalized for the same thing. So it is essential for improving that quality of care and then reducing healthcare costs altogether. And the Patient Protection and Affordable Care Act, that shift was toward that value-based care delivery system. Like we want to include our patient preferences. We want to think about everybody on the healthcare team. We want to identify if there's going to be any gaps. Like I said, your patient has to go outside of the facility for an appointment. Well, what things do they need to be present for in the facility? Because we don't want them to miss that either. Okay, let me go on to our next set of slides here. They're opening up. And it's never too early, you all. Go back and start looking at week 1 all the way. Look at the exam reviews, looking at all of that. Because remember, the bigger picture is you providing that best care to all your patients. NCLEX 1 time, passing your HESI. So all this information, it doesn't go away just, because we've mastered it. Start back. It's not too early to go back and start looking at all of that information. And, once you start seeing terms like this next couple of slides, assertive, aggressive, you can like, it's going to be, okay, got it. If you see a scenario, you got it. So just go ahead and just keep, replenishing yourself in that information. All right, let me share my screen here. And that's what all of your classes go back week 1, start looking at that information because you'll see it all again week 11. I don't know, some HESIs here. Let's see. From current slide, watching my time. Okay, as we've already discussed, we have those assertive, aggressive. I guess non-assertive is kind of in the middle, I guess, of those. But nevertheless, it's not, I think it is in the middle because you're not being, honest. I mean, you could be honest with being non-assertive, but you really are not. You're kind of, just going around what the real issue is or the real concern is and not giving the people the information that they need to know. So we have aggressive, non-assertive, and then we have assertive. Non-assertive, self-defeating, emotionally dishonest. Well, if I just don't respond to that question, then they'll just stop asking about it, or I'm afraid to. But then aggressive, it is attacking the other person. Like I think we said, insulting, belittling, leaning forward, those glaring eyes. That is not the same thing as making eye contact, looking away. And then assertive is honesty. We're using our correct, our body language is matching what we're saying. We're not changing, telling people what they want to hear. We're telling them the information based on, what the policy and procedure say, your doctor's order says, you're supposed to have Tylenol every 4 hours. Based on what's documented here, you last received it an hour ago. It's not time for me to administer, but I can, notify the healthcare provider that, you received it an hour ago, but you're saying that you're still in pain. And then we can ask those focused questions to gather more information. Can you rate your pain? Where is it hurting it? How long? Does anything help? Does anything make it worse? Okay. So negative interactions, coping mechanisms, projection, individuals attribute their own weaknesses to others. Rationalization, looking for, some excuse, trying to put it on something else. And then denial, the nurse can use this to excuse personal responsibility. I just signed off on it. Make sure that was what I just said. For example, you have to have a witness when you're wasting certain medications or you're administering. Some facilities want you to have a witness for administering certain medications. And so if you're signing your name, make sure that you're signing your name to what you actually did, that you really witnessed the actual disposal of, because hopefully nothing ever comes up, but you never know if it comes up. First of all, it's the wrong thing to do to be signing off on something that you didn't really do. And then if something comes up, guess who they're going to be asking? They're going to be asking those 2 nurses that signed off on it. So it's not going to be, reasonable or responsible to say, well, I just signed off on it because she wanted me to sign, the nurse wanted me to sign off on it with them. So that denial or is not going to be an excuse to get away with it. And you never know if it ends up harming someone that they can prove and all of that, and it's fine time. That may be jail time. So just make sure you're having to sign your name to something that you actually, that is appropriate. Sometimes there's conflict. There's something that's come up, but we need to figure out, well, what is the problem? Because sometimes it's really not what you're actually hearing people talk about. It could be something else. It could be something's wrong with the time clock and people's checks or the time on their checks didn't add up correctly. But really the problem is this time clock. It's not that the secretary was taking away their time. The time clock is faulty. it was glitching in and out. So, but how do we know that? We have to gather information. We have to align that information up to see if there's any gaps in that information. And then we may have to get statements. We may have to roll the cameras back. We may have to look at camera video footage to see what really happened. And then once we get to the resolution part, to see if there are any alternatives that, can we do what we're doing better with less time, with less resources? That's that spirit of inquiry that we talked about. But nevertheless, you're going to be that person that's going to be helping solve those problems. And so we want to make sure that we gather all the information. We may have to get statements, like I said, video footage. We may have to go back 3 shifts just to kind of get a bigger picture or a clearer picture to see what's really going on. So manipulation, feelings and needs of others are disregarded, or other people are treated as objects to fulfill the needs of the manipulator. Okay, so you want to set limits. Anytime there's any inappropriate behavior, that needs to be spoken about right then. You might have to do statements, but nevertheless, that if it's inappropriate, we need to deal with it. Unfortunately, there's a thing called assault. Sometimes patients it depends on why they're there. They may have a mental health crisis. They could have, their blood sugar could be so high or so low that it have them disoriented. And as a result of that, they can strike out. If a person is seeing or hearing things that are really not there, when you come in to talk to them, you of course be knocking on the door and waiting to get to come in, and then we want to introduce ourselves. Even with that, providing that reality reorientation, sometimes it depends on what's going on with that patient. They may be disoriented. And as a result of that, nurses can get injured on the job. And it's not because a person really was trying to injure you, but sometimes it really is. So just be aware of your surroundings. I know a lot of facilities, most of them, they don't want you to park up close. So they have like a designated area for employees to park. So just make sure, even if you're working in the daytime, just make sure you're looking around to identify if there are any circumstances that could put you at risk for something happening to you. A lot of facilities, there's one facility that you park pretty far off, but they have a shuttle service. It runs and runs and runs and runs pretty quickly, so that you're not late for clocking in and things like that, because they know they're asking their employees to park a good distance. Never mind the weather, it's raining, it's snowing, all those things. And then between here and there, think about if it's dark, if it's not well lit. And you might have to identify those things, once you start working in a facility, saying, hey, notice, it's dark. We're having to take out a thing that you used to have to do back in the day was take oxygen cylinders to this little, it was on the premises, but back to this little house because they had to be stored in a certain place. And it was kind of scary because, it wasn't a well-lit area. Sometimes you never knew when you had to take that oxygen cylinder out there. It could be dark, it could be early morning. And we had to identify, hey, we need some alternative. Can we wait? Can we store extra inside the building so this can be taken out during the daytime? Or if not, hey, we need better lighting. We need a buddy system. So you have to, talk all that through and just think about it once you decide to go to a place and work, because you want to be safe. So factors that lead to workplace violence, like I just mentioned, the patient comes in and they're hallucinating. They're not themselves. Then, that potential is there. So just make sure if they have a rule about wearing certain uniforms and shoes, if there's a certain rug or certain types of equipment, if it's not working properly, that rug is torn, we need to report those things, because we don't want we don't want to get home because, that door doesn't lock like it's supposed to. And then someone from the outside can come in and then, and harm us, the patients, and everybody. So just all of those things, it does matter. So just take the time to report those things. Be looking for, if someone's acting unusual, if there's lack of cooperation, if people become hostile, listen to what they're saying. If they are making uninvited sexual remarks, these things need to be reported quickly because we don't want them to escalate and spiral out of control and lead to harm coming to the nurse and the co-workers and other patients as well. So it says conversation focused on poor me, the victim notes with threats, violent or sexual content, stealing workplace property, increased arguments. We notice changes in our patients and our coworkers. We want to bring that to attention because people may have something going on. They may not even realize, they haven't been taking their medicines, or they may be it may be a situation they're dealing with so much, and they're not realizing that their responses are their responses that are not appropriate. So we do want, because most places have resources available to help. The nurses, the state nurses associations, for the most part, all of them have like these impaired nurse programs and things. And so the person realizes they're in that place, there is help out there. So that, there's help. There's help. So we do want to make a personal commitment to follow prevention guidelines. We do want to oh my goodness, we got another training. No, participate in those trainings and those refresher courses. Some places, if you're part of that education team, in addition to your other tasks, you might be the one that's offering those training courses. So make sure that you're getting the latest evidence information and make sure we're thinking through, pull the stats, what's happening out there, put it in your workplace. How can we prevent this from happening to us? So take advantage of those programs that are offered by the police department. I know with the state troopers, they have that, what's the little thing that they've been pushing? Is it shout, hide, run? Or I know I'm saying it out of order. You all know what I'm talking about. This is this program that they're pushing. They're just lay people, everybody. They're just coming around and getting people. What's the name of it? I know it's getting you to safety, but if someone's trying, I think it's an active shooter drill or something like that, but it's all related to violence. And so not health departments, police departments, those all type of those different, the FBI's, they have these programs that they'll come around and they will teach, they'll come to the churches, the places of faith, they'll come to the schools, they'll come so we'll know how to respond in the instances there's something going on, unfavorable conditions, because unfortunately it can happen. We want to be familiar with our workplace and our policies. Do we ever go out this door? Why don't we go out this door? Is this door locked? Is it supposed to be locked? Time is getting ready to change. You notice it gets darker earlier now. Some facilities, at what time do these doors lock? And so some facilities have their locks on timers. Have they changed the timers to match our current, lighting and dark time that it is? Should they set the timers so the doors are locked earlier? Do we have security? A lot of places don't have security 24 hours. So it relies on people locking the doors when they're supposed to. If there's something wrong with the lock, the keys, we need to be reporting those things. Because it's not only the patients that we're keeping safe, we want to keep ourselves as safe also. Sexual harassment is the unwanted abuse of power. We do want comments, gestures. We want to make sure that we are reporting that, getting it documented, letting them know right then and there, this is unwanted, because people will harm you. So make sure that, like I said, that you are reporting it and following up on it. Lateral violence occurs between nursing colleagues. Some examples include sabotage, withholding information. Unfortunately, yes, colleagues, this can happen. So if you're supposed to be a witness to something, come on, sign this. I've wasted it already. Nope, I can't witness it because I didn't see you actually wasted. So whatever it is, so just make sure, don't share passwords. just log in for me. I forgot to sign off on whatever. Nope, just take the time to come back to the facility or just, make note of it, report it to your supervisor, but don't share passwords because people can log in, and make sure if someone's always standing over you when you're logging in, be leery of that. Make sure because people can watch your keystroke and then they're logging in as you, documenting that they're doing things. Unfortunately, this could happen. So just be aware of that. So vertical violence. So we talked about lateral violence. That's nursing colleagues on the same team. And then we have vertical. It occurs between persons of unequal power. The behavior humiliates and undermines confidence. The person who is bullied ends up feeling fearful and unsafe. So nevertheless, it's still violence, but it's just between people that are not on the same they're on the same team, but they're not equal. So it's unequal. Okay. Insidious aggression. Aggressive behavior in the workplace, such as instability, interpersonal issues. This stuff, it can lead to, you being stressed at your work, leaving your job. Just make sure if anything is happening that's unfavorable, that you think is not right, make sure that you're documenting it, reporting it to the appropriate personnel. If they have that electronic system, make sure you're sending it appropriately, even if you are, because that's going to be timestamped and that's going to be there. So if you're sending something or writing something out, make sure you keep a copy of it so it cannot be altered, or just so you'll have it to refer to for your records. So a lack of action on the part of the nurse gives approval and permission for the perpetrator to continue the behavior. Call it out. If it's unwanted behavior, call it out, document it, because otherwise the perpetrator, well, they didn't say, they didn't tell me, that this wasn't what they wanted me to do or say. So a lack of action on the part of the nurse gives approval and permission for the perpetrator in their mind to continue the behavior. So call it out, write it down, make sure everyone that needs to know about it knows about it. I'm going to pause here and look and see if there are any questions about that. We do have one more PowerPoint to go over, and then that should take us to our case study, and then we'll get in our group. So just going back over our to-do list here. Okay, no questions in the chat. So hopefully you've been thinking about all of your clinical sites as you've been journeying through and thinking about which sites that might be a setting that you're working in, some that you might not want to work in. Almost getting time to be narrowing it down. Okay. So we're going to talk about the people on the healthcare team, the interdisciplinary healthcare team. Let's go. Let me share my screen here. Click on it here. Okay. All right. Okay. Here we go. All right. Who's on that team with us? The interdisciplinary healthcare team. We're all of that group of professionals and we all contribute. Every piece is important. While you're the nurse, it's kind of like that person, you're the person that they're going to be coming to. Even though they're on the team, you're like that leader. So we do want to make sure that we keep in mind that we're working together to meet this common objective, which is to provide this best care of this client so that they are restored to their optimal level of care, so that they can be able to manage, that they have all the resources. We know discharge planning starts on that mission. Even though by the time they get discharged, some of the things that we're thinking about, some of those resources, they may no longer need them. but we're trying to get them to be able to be back to their optimal, at least where they can manage it. So we're all there together. So we have all these different, it's even more than this, but this is just a few of them, the few of the ones that we mostly think about. So the dietitian, we have that newly diagnosed diabetic patient. We have someone that because of their cultural beliefs, they don't eat eggs, whatever, bananas, whatever it is. We want to, but that's what's on the menu for that day. Every second Tuesday, they have bananas on the menu. So who can we come in? Who can we get to come in to help us so that this patient can still get all the nutrients, the calorie counts that they need? Bring their dietitian in. They usually do like an assessment when they come in, they get all their likes and dislikes. But then sometimes there's that gap where they don't look at all those different menus that they already have in those food items. So, but hey, we just, put that, talk to that dietitian. The dietitian may have to come in and speak to that patient and see what alternatives. And sometimes it is our clients. If you have a client that might have maybe like Alzheimer's or something, and they're in that stage where they're busy all the time, and they're eating their food, but they're still losing weight. We may have to talk about what's next. Can we offer them? This person might have a problem with maneuvering the spoon and the fork to the mouth. A process that we really don't think about. This patient may need finger foods. What options, what menu options, can this person have? They can feed themselves, but there's an issue. Is there a different type plate? Do the spoons, the utensils, do they have and you all may have seen some of these utensils that have like a different, I don't want to say it's like they can grip the spoon and fork differently, but the dietitian, the occupational therapist, when we bring them in and they can help us give us insight on what can we do so this person can still be independent, feed themselves, and get all the calories that they need. So the social worker, they will assist us, on that admission, thinking about those resources that this client, this patient might need. They may need someone to deliver Meals on Wheels. Do we have a resource in this area? How do we get that application started? This patient's coming in, they may have, I don't know, some type of insurance, but it's getting ready to run out, or that insurance doesn't cover this medication. Is there a resource out there that can assist us in, so this client can still receive the medications that they need? The X-ray technician, you'll see this a lot of times, they have mobile technicians. They come in to do those X-rays. They need us or the unlicensed personnel or someone there to assist with positioning the client so that they can get their film and their boards in the correct place. So nevertheless, we are all there. In the scenarios, just go on and on and on. Think about when you're at clinical, those rotations, your preceptorships, that how you see the different people and everybody's doing their part, but they always come back to that nurse and say, well, hey, just want to let you know, you're like that centerpiece. So healthcare workers are the same discipline that work together to integrate care that will provide clients with all the services they need to maintain safety and that comprehensive healthcare. Those of us that are on the healthcare team, there's all different type of educational levels. Okay, and so here, this slide is just showing you the different levels, the different degrees, and the different up under each advanced practice nurses license. It's just showing you like the different tracks and things that you can, decide to do or not to do. That's what that slide is just showing you. So the role of the registered nurse, we have to, I think it's heavy on HESI about, and I think even some of your questions from this last exam was asking you what was appropriate for the LP and what was appropriate for the RN. Okay, so I'm going to make sure we read through this slide here. So the registered nurses, they plan the care, coordinate all activities of care, including care from the interdisciplinary healthcare team members, everybody on the team, provide care that requires more specialized knowledge and judgment, teach clients and families and other members of the healthcare team. They do their initial teaching. We as LPNs come back in and reinforce. and of course, act as that client advocate. So the role of the LPN, while we're not independent practitioners, we function more independently when we're out doing the head-to-toe assessment, when we're gathering that data. So we provide care in a basic and client situations under the general supervision of the registered nurse, the physician, the podiatrist, or the dentist. Primary responsibility is the care of the vulnerable populations with chronic and stable conditions. We want to ensure safety at all times. We want to be thinking about safety, no matter what setting we're in. We're in that skilled nursing facility. We're in that patient's home. Are we identifying, do they have these throw rugs? Is it well lit? Are the pathways clear in the hospitals or the skilled nursing facilities? Are alarms being, silenced in a timely manner? Are call lights being answered? Is this person a fall risk? Do they have on their non-gripper socks? Do they have on rubber sole shoes? Gotta always be thinking about safety. And of course, we're going to practice within our scope of practice, which comes from the Nurse State Practice Act, which the facilities, policies, and procedures should align. So we have the RN. They both can have memberships in their associations within their within the state, and then they do have some on the national levels as well. And once you join these associations, we have to keep up with those continuing education units. And a lot of times these associations, you can actually have the opportunity to get your CUs or continuing education units without having to pay extra for it, because it's they have different seminars and things for discounted rates. And some of them, even your state board of nursing will have some CUs that you can get without a fee. And it's like, you sit, you learn, you listen to the webinar. Nursing roles and role differentiation from care manager. So the RN controls decision of the staffing, controls decisions on the client care. The LPN, we can be first line managers. We can be that charge nurse in those skilled nursing facilities. We're not first line managers in acute care facilities, only in the long-term care facilities. So the RN initiate all phases of the nursing process and formulates those nursing diagnoses. The LPN assists with all phases of the nursing process, and then work with the established nursing diagnosis. Identify possible new nursing problems, and we collaborate with the RN. We talk about what we implemented this intervention. What was our outcome? So we saw, this right here, the patient, they didn't respond well to this, or the goal was met. Everything was taken care of. Okay. So the RN initiates, the LPN reinforces that client teaching. So think about, but we both teach, but that the RN does that initial, and then we can reinforce and assist the RN with the teaching as directed. So watch for those words again: all but, initiates, reinforce. Okay. So the RN to BSN program includes research theory, interprets and implements evidence-based practice guidelines, participates in research process. LPNs, we assist in implementing the evidence-based guidelines, and we can collect data. We can collect that data, and that data is measuring height and weight, vital signs. We can collect that data for the research. Okay. So the expanded role of the LVN, that charge nurse, we just talked about that. We can be charge nurses in that long-term care facility. Okay, we're going to consult with the registered nurses. We assist with decision-making. We talked about that care coordination, and we can assign and supervise unlicensed personnel as an LPN. This could be LPN or LVN in the long-term care facilities. Okay, so delivery of nursing care in the acute care settings. So we're working under that registered nurse. We do want to always keep in mind this care coordination. Okay. Are there any questions? We only have a few more slides, and we're going to go to our case study here. So client-centered relationship-centered care philosophy, providing care that is respectful of and responsive to the individual client preferences, their needs, and the things that they value. So we got to find out what they value. What are their preferences? And then we want to incorporate that in by client care, because sometimes it's not the client just being non-compliant. That's not something that they have a need for. That's not a preference of theirs. That's not important to them. So we can find out, by interacting with our clients, what their preferences are. And then that information will help us, better come up with interventions for our client. And, we provide that individualized care to make it more individualized. So the nursing shortage, we've been in it for a long time. And so we have seen different things happen over time that lessens or shorten the nursing shortage. And so we see the different programs being offered: hybrid, online, part-time, day, night. You see all of that there, because the need is there. We have so many different facilities. There's so many different settings we can work in. And so with that being said, we need more nurses. And so just be thinking about, think about daycares, school nursing, industries. You're the nurse on site at an industry. You might be even that nurse that goes and start the health screenings, do part of the health screenings. You may have to go to people's homes. You may have to go to a site. And there's just so many different areas that we as nurses can work in. And that we're needed, flu shots, flu season, people, we're not for vaccines. We're not against vaccines, but they have flu clinics. They have these different clinics. They need people to work. And so the opportunities are there, but because of all these different opportunities, it's created a nursing shortage. And so if you come up with something, be an advocate, talk to your politicians so they can create and change things up so that we can lessen this shortage, hopefully get rid of it altogether. And so, because of the evidence-based, the latest in research, people are living longer and healthier lives because now we know what high blood, the silent killer, does to us. So we know we need to be checking our blood pressure. We know they have a blood pressure screening, get your blood pressure checked, see what that blood pressure is. So now we know, okay, we need to be doing something about it. We're decreasing the amount of salt. We're walking, we're increasing that physical activity. And as a result of that, people are living longer and healthier lives. But nevertheless, they need those nurses to be there to help provide those services in all those different settings. So like now, before, I can kind of remember when it wasn't really urgent care centers. You either went to the doctor's office or you went to the emergency room. Now we have urgent care centers everywhere. Doctor's offices have alternate schedules. So they're open, for more than just 8 hours. So with that being said, we need more people to work, more nurses to work. So important concepts. Each member of the interprofessional healthcare team provides a valuable service to the client. We're all important, you all. That client needs us. They need all those skills in the services that we're going to provide. To understand where the licensed practical and licensed vocational nurse fits within this healthcare team, we want to be aware of educational background. What are those roles and responsibilities? We want to be aware of that Nurse Practice Act because we don't want people practicing outside their scope. So be careful because people might not know what your scope of practice is. So it's on you to know, because sometimes people will ask you to do things that you're not supposed to do. Not because they're maliciously trying to do it, but they could be trying to sabotage you. So, because we just talked about that. So remember that. So arm yourself with knowing what it is, what's in your scope of practice. The Institute of Medicine, the IOM, defines patient-centered care as providing care that is respectful of and responsive to that individual client's preferences, their needs, and their values. We want to know what they deem important. What's their understanding? What do you know about this health condition? What's the goal for you? We want to know what our patient, what goals do they have? Because again, like I said, it's not that they are being non-compliant. Sometimes it's not of value to them. It's not a concern to them. So we'll go ahead. We're a few minutes early, but we can go ahead and take our second break. So when we come back, we can do the case study, and then no, let me send the case study to you. That way we'll spend the last part of our time in our groups. So let me send it to you, or we can work at it. Let's do it let's just do it together, because we only have 9 minutes until our next break. And then we come back, we will do our group stuff here. So let me pull it up here. They're having all this little stuff lined up, and it just kind of goes somewhere. I don't know where it's going to, you all. Where did it go? Go back and download it again. So I'm looking in chat. I don't see any questions. All right. So again, make sure that you are doing your required readings, making sure you're going back, looking at the recordings, be looking at your exam review dates that are coming up. There are 3 of us. And so be looking at that schedule. If not, if you can't attend, please commit to at least going back and looking at the reviews. Remember, I know we're ways off from week 11, but remember, week 11 is going to look different from the rest of your weeks. So especially if you're taking more than one class, your HESIs might not be on the same day of your classes. So I know it's kind of early, but just want you to be thinking about, what work, childcare, whatever responsibilities that you have maybe changed a little bit that week. I mean, it's asking me to log in again. So just bear with me. Weather, I'm not sure how the weather is where you're at. So just be making sure that you are, staying weather aware. So I want you to be safe. Okay, I have it now. It's opening up. Okay, so we're gonna work independently, but I'm gonna just look through we have 8 slides. One of it is an introductory slide, so we only have 7. So there's a case study, and then there's a few questions here. So we'll just talk through the first couple of slides, and then we'll look at the case study. Let me share the screen here. We may just do it all together rather than do it independently. Let's see, because we want to use our other time. Okay, that's what we'll do. Okay, communication, we talked about keeping in mind of patient safety, no matter what the setting is. We want to include their preferences. What are those things that's important to them? Their cultural beliefs. We always want to advocate for that client. If they ask us questions, remember, we don't give advice. We want to make sure they have enough information so that they can make an informed decision. And we're collaborating with everyone on that healthcare team to ensure this client gets back to their optimal level of care. We talked about assertive communication is therapeutic. It is positive. It's being honest, to the point, when we communicate that in a non-aggressive manner. We talked about handoff, the S-bar. We're going home and our next nurse is coming. We got to give them that information that occurs so they can have their baseline. So when they go in to actually assess the client, they have something to compare to. So status of the patient, team members, we talked about all those that are on the team, consider them environment. Is this patient getting better, or are things staying the same, or are they getting worse? Okay, remember the chain of command. We want to be reporting things that should be reported. Under rules of assertiveness, always go to the source. Someone's unwanted behavior, we need to Go to that source. If there's something going on your unit, on your team, on your hall, depends on where you're at, is what they call them. Just make sure the different people that are over those different departments. And who do you go to in the event that there's conflict, that there's a broken door handle? Who do you go to? Know who that is. And this is an example of the nursing chain of command. And then, you never know. You want to be over all of the nursing staff, and then chief nursing officer. You usually see those at health hospitals, but director of nurses, you do see those at skilled nursing facilities as well. Okay. The quality and safety education for nurses that QSIN initiative anticipates that collaboration will have a major impact on positive patient outcomes and improves quality of care. Communicating, thinking about safety, coordinating that care, nothing but positive patient outcomes. So here we go. Here's the case study. So let you look at let's see. No, let's just read the case study first. So we'll give you time to read. Got 4 minutes, as I want to be good stewards of your time. Let me be quiet so you can read. Okay, are we all finished reading for the most part? Okay, so someone give us just a synopsis of what happened in this case study. What's going on? Give us an overview, paraphrase, a shortened version. So come off mute and tell us about it.
So it's basically about how there's a new nurse working on the ICU floor, and she is being trained by somebody who has 20 years of experience, 5 of which she spent in the ICU department as well.
Okay. Her first day. So in this right here, this residency program, even if you go to a place to work at, they have like all these, and this is just some aside note, you all just be looking on those boards, asking if there are other things that you can participate in, because there's so much that going on at these places that we work at. So besides your normal day to day, there's other things you can do. So good. Thank you for that. I think that was Nicole. Thank you. All right. So what are 3 attributes of effective communication noted in this case study? What are some effective communications? Tell me all about it.
She was welcoming and inviting to the new person, and she instead of making her feel intimidated about being there for her first day, she reasoned with her and like leveled with her to make her feel welcome and comfortable.
That's good. Good. Anyone else? Was there any one
She was.
verbal? Oh, go ahead. Sorry.
Oh no, I was just kind of adding on to that. Seeing she was just being positive and relatable to it, and using her expertise of being there for a while to understand like where she's coming from.
Great. Thank you for sharing. What is one verbal or one nonverbal communication example in the case?
There was a nonverbal with her walking up, approaching her, smiling. So it's inviting.
Got it. Good. Thank you. So what is the impact of culture in this case?
The culture that comes across is teamwork and supporting one another.
Exactly. You got yours, I get mine. I got mine. You got to figure your way. No, it wasn't that. It was inviting. It was the opportunity. For growth. Person would not have been afraid to ask questions if they had questions. Great, great, great. All righty. Thank you all for sharing. We're gonna stop here and we're gonna go to our next break. We kind of come back. We're gonna, do our group thing, and that'll take us on out. All right. See you in 5. All right, I am going to open up the breakout rooms. And I think I have everyone assigned. Nope. Let's see. Trying to. Okay, Tiara, what's your last name, Tiara? Let me go back and see what it is.
Murray, Murra.
Okay, got it. Okay, let's see where you're at. Okay. All right. Okay, so we'll open up the breakout rooms. And remember, this is not the only time that you should be communicating, revising, thinking it through, and actually implementing whatever it is for your final product. But we're going to give you this time here. So I will circulate around. I'll go ahead and do a recap while you all are in there. So I'll still be recording. And then, of course, this will be uploaded and shared. So, but I'll bring you all back. And we haven't taken our last break, so we're going to do that at the end. So you actually have about 18 minutes to talk through and decide and discuss. But I'll bring you all back when it's time. All right, I'm going to open up the breakout rooms. Let me know if it puts you in the incorrect room. I think I have it correct. Is it allowing you to join or is it stuck? So I may have to move you and then put you back if it's okay. So we mentioned earlier about the different parts of the interdisciplinary team members, everybody that's on the healthcare team. Each person, each member is just as important. But be thinking about the individual, the specific task that each person plays. We know the physical therapist, the occupational therapist, they focus on mobility and activities of daily living, while the respiratory therapist focuses on breathing issues. Okay. And so the speech language pathologists, though they specialize in diagnosing and treating speech and swallowing disorders. So, for example, if you had a patient that's had a disease process, one I can think of right off is like a stroke, and they have had problems. If they want to see if their swallowing has been affected, that's where we'll bring in that speech language pathologist. And they can do those different tests to determine whether or not this person, in fact, has a swallowing problem or not. In addition to that, sometimes a person may have a problem with chewing, so they can recommend that those diets, those meal items, those food items be pureed or be mechanical soft. In addition to that, the liquid can come in different, what's that word I'm looking for? Thickness. That's not the word I'm looking for, but water, if you think about it, water is really thin. But if you compare water to honey or nectar, those are different consistencies of a liquid. So if a person Sometimes people will need that water thickened so that they can swallow appropriately, and it may be nectar consistency or honey consistency compared to that thin water that a person would normally drink. So that speech pathologist, speech language pathologist, they'll do all those different tests to determine whether that person has a problem with swallowing. And like we said, respiratory, they're that person on that team that deals with us. Respiratory, respirations, lungs, think about oxygen, safe usage. The respiratory therapist is responsible for managing oxygen therapy, including education on the use of and the safety of that equipment. Remember, the nurse is going to collaborate with all of these different people on the healthcare team to ensure that the clients are receiving that proper care, whether that is proper respiratory care, proper physical therapy. You know, that nurse is going to be like that little hub, that person in the middle, that glue that holds the team together. Okay. And so,
Professor Ford, I'm sorry. I don't know what happened. My Zoom had logged out. Can I be connected back to my group?
sure.
Thank you.
Let's see. I think after so long, these things, I don't know what it'd be, but it'll log you out for no evident reason. Let's see. You are, sure, okay, room 2. Okay, you're in room 2. Okay. Collaboration with those on that healthcare team. It's going to contribute for that better care, those better outcomes, that improve quality of care for our patients, you all. That QSIN, that's an initiative. It focuses on making sure care is not underutilized, that there's no gaps, misuse. The bigger, the best, the goal is provide that best care you can for that client so they will have those better outcomes and have that improved quality of life. We've been talking about communication today, but remember, we always want to be listening, have that active listening, because like I say, they're going to be coming at you because you're the nurse, you know, from all directions, everyone on the healthcare team. But you do want to make sure that you're actively listening and, you know, that we're contributing relevant information about our clients. Effective collaboration in an interdisciplinary team involves active listening and sharing relevant patient information. This approach ensures comprehensive care planning and promotes the integration of diverse professional perspectives for that optimal patient outcomes. It gets them back to their optimal level, back as close to their norm as possible. It allows them to be able to manage themselves in the event that they go back home and that they're independent. So we're going to be talking about delegation next week. And so delegation requires matching the task to the appropriate level of education and in the scope of practice. Unlicensed assistant personnel, they can assist with non-complex tasks such as hygiene and mobility. Okay. Now if those, making sure those clients are stable. Once those clients, if they become unstable, then we want to reassign that unlicensed personnel. LPNs, you know, think about, we administer medications and we monitor those stable clients. We can administer medications. We can do dressing changes. We can insert Foley catheters. We can remove those Foley catheters. We can do wound care. We can administer tube feeding. Just think about all those different tasks that we can complete as the nurse. Unlicensed personnel, as long as that client is stable, they can assist with bathing, they can measure vital signs. We're not asking them to interpret, saying, hey, this blood pressure is high or this blood pressure is low. That measuring vital signs, they can empty Foley catheter bags. Well, we're not, they can even, in some settings, they can even check glucoses. But finger sticks, we're not asking them to interpret anything though. As long as the task that we're requiring them to do does not involve complex assessment or decision making. Because we have to go to school and learn. We talk about critical thinking, decision making. So that's on us as the nurse. But measuring vital signs, assistance with bath, turning, repositioning, that's within the unlicensed personnel, the nurse's assistant, patient care tech. Those titles are kind of used interchangeably. They can do those tasks. But any task that's going to require complex assessments and decision making, that is on us as that nurse. Okay. Delegation should be based on the patient acuity. This is patient stable versus unstable. And then the staff is competence. This ensures that patients receive appropriate care from the qualified staff members. This promotes safety, effective patient outcomes. It lessens conflict, it lessens malpractice, it lessens negligence. Effective delegation requires the nurse to assess whether the task is appropriate for the skill level and the scope of practice of the person that the task is being delegated to. Okay. Effective delegation requires the nurse to assess whether or not the task that we're asking them to do, if it's within that person's scope of practice, it ensures patient safety and compliance with the legal and professional standards. Remember the Nurse State Practice Act. If the client is unstable, it changes everything. That client must be stable. We want to avoid delegation, that a task that is outside of the scope of practice. Now, just because we delegated, it does not mean that we are relieved of that patient's care. We should still oversee, ensure that whatever task it is that we're asking them to complete has actually been completed and correctly. We should communicate to them all the different parts, the instructions correctly. What is the task that we're asking them to do? Should the results be written down or should they be communicated verbally? Okay, let's talk about assigning. Assigning involves distributing tasks that are within a routine job responsibility of that staff member. Okay. In contrast, delegation involves transferring the authority to perform a selected nursing duty in a specific patient situation, typically requiring more careful consideration of the task complexity and the individual's competence. Okay. So assigning is asking that person to do something that's within their job responsibility. Delegation involves transferring that task to that person that they might not necessarily would have done. But you're not asking them to do anything that's out of their scope of practice. So delegation requires matching the task to the appropriate level of education and the scope of practice. While the chain of command is important for organization, structure, and communication, it should not impede urgent patient care or safety concerns. In emergency situations, immediate action may be necessary by bypassing the usual chain of command. Healthcare professionals have a duty to report critical issues directly to those who can address them promptly. Let's talk about this. Let's go over the chain of command again. While the chain of command is important for organization structure and communication, the chain of command should not impede, slow down, stop, hinder urgent patient care or safety concerns. In emergency situations, immediate action may be necessary, which might include bypassing the usual chain of command. Healthcare professionals have a duty to report critical issues directly to those who can address them promptly. Following the chain of command rigidly in all situations can lead to delays in care. So there are some times when, the chain of command will not be considered in emergency situations, because in emergency situations, we need an immediate action. Effective healthcare delivery requires flexibility and judgment in applying organization protocols. Many facilities have policies that allow for direct reporting in urgent situations because they know that chain of command is an emergent. We need an immediate response. So they have policies already in place. We need to understand when to adhere and when to deviate from the chain of command. It is crucial. It is crucial in that clients' outcomes, they're going to depend on it. So the following the chain of command starts with addressing the concern directly and professionally. If the unsafe practice continues, the practical nurse should follow the proper hierarchy. We have the charge nurse, got the nurse manager, the nurse supervisor. Documentation is going to be essential, so we're going to make sure that we document everything. Talk about competence. Competency means understanding your scope of practice and your skill level and knowing when to ask for help or delegate. Empathy and compassion, they're valuable traits that we should have as healthcare professionals. But competency, meaning that you have that understanding, and then you're able to practice within your scope of practice. And when we need assistance, we know when to ask for it. No, don't be above asking for assistance if you need assistance. So that competence, it comes from this theory, it comes from your required readings, working as a group, it comes from writing your papers. It's a combination of that theoretical knowledge. And then it's, in addition to that, you act those practical skills that you've gained, and then that sound clinical judgment. You go in, you receive report from the handoff report from the nurse that went home, and you go in and you assess the client, and you have different findings. The level of consciousness has changed. Then you have that clinical judgment or that understanding to say, well, wait a minute, this is a change from what they reported, that they said how this patient has been all shift. So competence in nursing involves combining theoretical knowledge with practical skills and the ability to make those sound judgments. So think about the information, that foundation information that you gain from reading, from participating in class, from going through your NCLEX questions, for preparing your papers by looking up, the last evidence information within the last 5 years. Think about those skills that you've gained that you practice in the skills lab. And for many of you all, you've actually performed in the clinical setting. Okay, we're closing the breakout rooms. Hopefully you all have utilized your time together. But again, make sure that you're reaching out. Hopefully you have some type of communication, whether or not that's text message. You know, you all have all these fancy ways of different ways of modes of communication. So make sure you all use whatever is best for the group. It might be best to have more than one way of communicating, just in case, because you know, connectivity with these that storm that's brewing out there. We don't know how connectivity is going to be. Like we had a whole bunch of rain early this morning, so you just never know. So I would suggest more than one way of communicating, just so that we don't miss what our group members are trying to communicate to us. Because you know we don't want it to be that they're not participating. You know, if the message isn't received. So,
Wow.
was there a question? Oh, you were just coming off mute. Okay. All right, then. Well, we will make sure, and I keep repeating myself, make sure, keep it going, keep it going. You all review the classroom recordings. Go ahead and continue to working together so you can have that best product. Start back on week 1 with all of your classes that you're taking. So you'll be ready for the NCLEX, the HESI, you all. You all take care and have a good night. Did you all have any questions? Miss Nicola, Miss Smith, Miss Latricia?
No, we basically just was going over our topics and